Let's get started, and let me welcome you all around the virtual table here on Zoom. Thank you for joining us. My name is Oliver Schmidtke. I'm directing the Center for Global Studies, and I have the great pleasure of leading you through today's session on Boomerangst, Affording an Aging Population Long-Term Care by Michael Wolfson. Before we start off, let me point out that although we meet in a virtual room, we still would like to acknowledge with respect the Lekwungen-speaking peoples on whose traditional territory the University of Victoria stands, as well as the Songhees, Esquimalt, and the Saanich peoples, whose historical relationship with the land continue to this day. And I think we have seen the importance of place, of communities over the past couple of weeks, and we have made repeated reference to some of the practices and the experience of First Nations and how it could lead us as well in our collective endeavor with respect to a whole range of issues we've been tackling. So for today, we had to switch to a different format, but the same housekeeping items, if you have joined us before, still apply. Please mute your mic and turn off your camera as we go along. It makes it much easier to proceed with the presentation. And then afterwards, you can either raise your hand, and I'm going to call upon you to ideally come in with a microphone and your camera, so we see you, a bit more of a sense of community on this Wednesday, or you could leave your comment or your question in the chat box. That's also possible. So with this, I would gradually like to move to introducing our guest speaker, and we are very happy to have Michael Wolfson back at the Center for Global virtually this time around. He's joining us from Ottawa. As you can see here from this slide, Michael Wolfson has a very distinguished career in the public service. He joined as a trained mathematician, computer science, and scientist and an economist with a Ph.D. from Cambridge that he received in '77, and he's really been the wizard in terms of knowing how the numbers work, statistics. And you can see here has a whole range of positions in the Treasury Board Secretariat, the Department of Finance, the Privy Council Office, the House of Commons, and the Deputy Prime Minister's Office. But Michael Wolfson's main occupation in the civil service was to work in the statistical office, and he retired as the Assistant Chief Statistician at Statistics Canada in 2009. And after this, he was awarded the Canada Research Chair in Population Health Modeling in the Faculty of Medicine at the University of Ottawa in 2010. So you can see he brings this wealth of experience in thinking about health and how data, comprehensive data that we have, can inform better policy making. And we're thrilled that he addresses an issue that in a way might be on many people's mind, because with the COVID crisis, we have seen what the pandemic and what kind of challenges the pandemic has generated for the healthcare system, and in particular, people that are older that have some form of assistance. And in this respect, Michael will address today the issue of how do we respond to an aging population, the increased need for care, and what has the recent experience with the COVID pandemic told us about the feasibility, the affordability of providing this care at a quality that is appropriate, because we have seen these horrific scenes of abandoned nursing homes basically in the COVID crisis. So Michael, it's wonderful that you could join us to shed some light on this challenge, and I give you the floor. I'm gonna mute my mic and turn off my camera, and we look forward to hearing your presentation, and you're gonna share your PowerPoint in a second here. Michael, thanks so much for being back.
Well, Oliver, thank you very much for the very gracious introduction. Now, what is not clear to me is my screen being shared right now or not?
Not at the moment.
Hi, Michael.
So how do, yeah,
Stephanie, remember you have it open on your screen, correct?
yeah, just, oh, here it is.
Yeah, so I've made you a co-host of the event. And if you go down to share your screen at the bottom, it should activate it.
All right. Is it now shared?
It is now shared.
Okay. Well, again, thanks for the introduction, and I'm very happy to be able to address folks there in the University of Victoria, even though from a great distance. I'm going to organize my remarks roughly into three broad buckets here. First, a bit of general information on Canada's demographic future, a few slides on how health care costs generally are likely to evolve, and then in particular focus on long-term care. One of the big concerns with long-term care and healthcare in general, along with pensions, is the fear encapsulated in this "Okay Boomer" meme about the fact that there are very large intergenerational transfers that are apparently involved, really involved, and that these may be a source of intergenerational conflict. I can't resist digging up an old quote from The Economist from over 20 years ago to say that most of what's going on is differences between rich and poor, not between different ages. And Maclean's picked it up just earlier this year to talk about the War of the Ages. But as a preface here, why do we have long-term care? And first, there's a concern about the way the word is used. In my remarks today, I'm going to use long-term care to refer to both home care and nursing home services, sometimes referred to continuing care. The provinces across the country have different words here. And in general, we should expect that Canadians can receive adequate long-term care. Ideally, government's fiscal responsibilities should not be or become unsustainable. Canadians shouldn't just leave it all to the government. They should make some sort of provision, but this is a risky question, how much long-term care you might need. We would not like to be, as in the US, where someone might face bankruptcy or undue distress or premature death, and we don't want family members to be excessively burdened. So those seem to be reasonable objectives. First, our population. What I've shown in this pair of graphs is on the left, the overall population in the solid lines, and in the dashed lines, the population living in households. And the gap between the two are those people who are living in collective dwellings. StatCan only started doing a decent job collecting this information in 2011 census, and I've updated that to 2016. You see there's a huge gap for women on the left side. If you can see my cursor around here, for women in collective dwellings, less so for men. And amongst those, and you see 1.2 million individuals here. And on the right-hand side, these are people living in seniors' residences, are very important, the private sector, and particularly at ages 80 and over, then nursing homes, and then some mixture type dwellings. The population is certainly aging. We're going to be living longer. This is the population pyramid from StatCan's middle level demographic projection out to 2050. And I've circled the two little red bits at the top to show that by comparison, if we assumed that there was no improvement in mortality, we'd have just, I'm a little colorblind, the blue bars. The red bars indicate how many more people we can expect given StatCan's projection of the decline in mortality. I was informed recently, I heard a talk by Alan Lopez saying, it's really quite strange, but there seems to be a leveling off in mortality improvements. So I went back and dug out the most recent data, which only go to 2018. And what you see circled in these ovals here is it looks like in the last 6 or 7 years, there's actually been quite a leveling off in life expectancy. There were some fairly level periods earlier on, but this is a caveat in terms of the future projections. I've fitted the dotted lines are just eyeball straight lines on the mortality trends. So the projections I'm going to show you are based on an assumed continuing increase of about 2 years per decade in life expectancy for men, a bit less for women. These are population projections broken down by 10-year age groups. David Foote wrote a very popular book, I guess it might be more than 20 years ago, entitled Boom, Bust, and Echo, where boom referred to the baby boom cohort, the bust was the decline in fertility, and the echo was the children of the baby boom. And what you see here going out to 2070 is what the population will look like. So you see here the baby boom in the decade 65 to 75, and then 10 years later, where did my cursor go there? And 10 years later, still here. And this is the echo population. So that's the broad demographic story. The demographers and the media are very fond of doing a simple bunch of arithmetic where they compute the ratio of the population 65 plus to the working age population 18 to 64. And in this case, the projections are old. They only go up to 2031, but you see a dramatic increase. If you include the children, 0 to 18 or 17, for the total dependency ratio, it doesn't look quite as scary. But this is not the best way to think about what the burden of an aging population will be. An alternative is to look at how many hours of paid work there will be in the economy. And the top curve is both, and then you see males and females. And the little dashed line over here says, well, let's look out to 2031. And that really brings us back to about 1991. This is a bar that indicates how many hours per capita, according to the OECD, were being devoted in economies in OECD countries. And we're workaholics in North America, Canada and the US, because we're up here, whereas many leading European countries seem to get by with many fewer hours per capita. So that there's lots of room, if we think about, or if we were to organize ourselves differently, to say this is not going to be necessarily a huge burden. So the body count, as I like to call it, old age demographic ratio, will certainly increase, but using this more relevant measure of paid hours per capita, Canada's level is projected to fall by less than 10% and will remain about 30% higher than a number of wealthy European countries that today already have higher conventionally measured old age dependency ratios. I have to know that the analysis here, I'm basically drawing on some old slides. It's more than a decade old. It was done using a computer microsimulation model called LifePaths, but the funding for it was cut. And unfortunately, this kind of analysis doesn't seem to have been picked up and extended, at least as far as I can see. Let's turn for a few minutes now to look at how much money is being spent on health. Here's a graph that comes from the Canadian Institute for Health Information, and it shows per capita spending by 5-year age groups along the horizontal axis. And you see that that curve goes up dramatically as you move to the higher age groups. And aging would mean that people would shift from this age group to the next age group up and say, wait a minute, wow, that's really scary. We're going to face a huge burden as a result of aging from increasing healthcare costs. The Parliamentary Budget Office, a decade ago now, did a similar graph. This time for each age group, they had 3 bars covering almost a 10-year period with these per capita expenditure numbers. And if you look at what's going on within each of these 5-year age groups, as I click and you see these blue lines, there's a tremendous increase in the amount of money being spent within a given age group over a period of less than a decade. The PBO put this very politely, saying the population and healthcare enrichment is what they called it, would put significant pressure on health spending. Others have referred to the medicalization of old age. So we need to be careful not to ascribe to an aging population the major causal factor, treat it as the major causal factor for increases in healthcare spending. It's become quiescent now with the pandemic crisis, but pharmacare could save lots of money. Not clear where that's going to go over the next little while. So is there a great tsunami of healthcare costs? Well, if we divide the healthcare sector into 4 broad categories, with respect to hospitals, I haven't shown the data, but there are small area variations where, for example, you can have 3 times the chance of having heart bypass surgery in one part of the country than another, with no apparent benefit in terms of your survival. So somehow, if those data were regularly used and studied, there's continuing evidence that there's a lot of inappropriate care, should we call it waste and inefficiency, so that I'm reasonably comfortable that we can bend the cost curve for hospitals, we can bend the cost curve for physicians, with primary care reform, more substitution of nurse practitioners. We can contain costs for drugs with pharmacare. So those all provide opportunities for major cost savings. But what about long-term care, which is what I'll spend the rest of this talk on? So to start, here's some the most recent data that are available from the OECD showing how much is being spent. Here's Canada on long-term care, about 1.6% of GDP. Here's Norway, Sweden, and the Netherlands, almost double that. And if we look more closely, there's variation among those 3 countries, but the number of long-term care workers per 100 people aged greater than 65, Canada's at half what the Netherlands is and 1/3 what Norway and Sweden. So they spend a lot more money, or they devote a lot more resources to providing the hands-on care. In terms of number of beds per 1,000, Norway is somewhat less than Canada, but Canada's a bit more than Norway, in other words. But in terms of beds, we're about half the level of Sweden and the Netherlands. So it is possible, looking at other countries, to see quite different ways of allocating resources to long-term care. So now let me turn to some projections. And for this, I'm going to use the Life Paths model. It was widely used for pension policy analysis. As I noted, it was mothballed after 2010 due to budget cuts, but the source code is still available, as I say, for brave geeks. And Bonnie Jean McDonald and I worked together over the last several years. Bonnie Jean did wonderful work in order to bring that model, keep it alive, and do some further work. Inside the model, we already had some sophisticated disability dynamics that were estimated by Jeff Rowe inside StatCan from the National Population Health Survey. That's old, but the NPHS was also cut in 2010. So the best longitudinal microdata we have on disability and how it evolves, that's the best there is right now. So we recalibrated it to the recent Canadian Community Health Survey. We used a simplified way of talking about disability. And we were also able to use what's called the inter-ride data that John Hurdy's kindly provided from UWaterloo to measure things consistently between the CCHS, the NPHS, and all that. And we used the 2016 census for where people lived in retirement residences. As far as key assumptions, even though the old age security and the guaranteed income supplement are indexed to prices, they have been on an ad hoc basis increased from time to time, and we can discuss it, but my default assumption is that over the next 30 years, they will effectively be increased in a way from time to time to keep up with the size of the economy, with wages. Similarly, even though the individual income tax is price indexed, I've also assumed that it's going to be wage indexed in order to avoid bracket creep. As far as disability, there's been a huge debate on what's called compression or expansion of morbidity. Until recently, there really wasn't any Canadian analysis. There's quite a bit of unconverging analysis in the US. But the story that came out from a recent study of 20 years of StatCan data was that the ratio of health-adjusted life expectancy to life expectancy was generally constant. Health-adjusted life expectancy, by the way, is a measure of life expectancy that instead of assigning a 0 if you're dead and a 1 if you're alive, assigns some sort of number less than 1, 0.8 or 0.3, depending on how yucky you are, yucky being a very technical term. So we've assumed that what Jean-Marie Rabin calls dynamic equilibrium. For long-term care, which is defined as home care and nursing home services, we added modules, and we've assigned some unit costs. I'll say a bit more about those in a second, and assume that those increase also in line with average wages. But let me say that this has been a real struggle because the disability data generally are a mess. Aside from the surveys that I know best, the CCHS and the NPHS, which used a standard and consistent terminology, the surveys like the post-censal health and activities limitations survey and the various other surveys, I have to say these are surveys that were funded by EIC, now ESDC, and every couple of years the people responsible would change and they'd want to do a new survey. So the idea of having any kind of consistent time series was not part of their interest. In any case, this is the results of the projection on disability status, 2020 population pyramid on the left, 2050 on the right. Darker colors mean more disabled. And you see that there's quite a substantial increase in the 85 plus population here. But let me also emphasize how much of these pyramids are light blue. So even though there's this image that once you get to 75, 80, 85, you're old and decrepit, most people are not really seriously disabled. There's a minority, but you can't predict whether you're going to be in the dark color or the light color in general. There are obviously risk factors, but nothing is certain. We then turn to in this case, the 2006 Participation and Activities Limitation Survey. It's not the most recent survey, but it had the largest sample size. It was a post-censal survey. And what you see is in the darkest colors at the top are people who said they needed care. Some of them needed care even though they received it, and others said they needed care and didn't receive anything. So those are the darkest parts. Again, I'm losing my cursor. So these are there are more recent surveys available, but the questions kept changing. They generally give similar patterns, but they had smaller samples. So these unmet needs are not huge, but still it looks like from 10 to 20% over age 75 are reporting non-trivial unmet needs for home care. Our projections then looked at how much home care was being received. The left graph shows 3 curves with 700 million hours on the top of the vertical axis here. This is informally provided care. This is publicly paid, and this is what people are paying for privately to the best of our ability to estimate and project this. The critical thing is look at how large the informal provided care is. On this side, on the right-hand side of the graph, this is the average number of people that future elderly who need home care can expect to have by way of spouses or adult children. And we know that the fertility rate has been declining, the marriage breakdown rate has been increasing, so that the average number of people who are available as close family members who could provide informal care is dropping over the next 30 years. And if we put together this curve with this curve, this is the average number of hours per informal caregiver. So the people who are available, if they all chipped in, would need to provide significantly more care. Costs of long-term care services. I've quoted here Michel Grignon and Byron Spencer, who had an article 2 years ago where they tried to figure out just how much Canada is spending. And they looked at both the Canadian Institute for Health Information and the OECD data. And they basically conclude that the data are terrible. They do careful work to try and adjust for the various gaps and problems they saw. But they basically say that these data are useless for serious purposes. But for our purposes in the simulation modeling, we are interested in two main unit costs. What is the cost per hour of personal support worker or skilled nursing or physiotherapy services? And we've assumed $30 an hour. That's not what the PSWs, the personal support worker, gets paid. That's including the overhead. And based on not the best statistical method, informal conversations with various people who are knowledgeable in the sector, nobody objected to that. And then the cost per bed day of $175. Now the actual cost is higher than that, but in general, nursing homes recover a substantial amount of the old age security pension that people would be receiving. So we have the unit cost, and then we have utilization rates based on our projections by age, sex, and level of disability of the number of hours that people need for home care and the number of bed days. So unit cost times physical consumption equals total cost. So these two panels show the resulting projected costs. On the left, you see the costs in constant dollars, billions of dollars. And on the right, these are the figures deflated by our projection of the average rate of real wage growth, 1.1% per annum, in order to show the costs relative to the size of the economy. I know the journalists like to look at the dollar numbers. My preference is to look more at how large these things are as a percent of the economy. And in order to put the long-term care costs in context, this is the cost of old age security. And what you see is the baby boom, bust, and echo happening, in this case for the 65 to 75-year-olds, and then the 75 to 85-year-olds. This is the cost of long-term care, home care plus nursing homes as projected. And it's relatively level up to 2030, but then it really starts to increase quite substantially thereafter. Now, there are all kinds of uncertainties, and the results that I've just shown you are sensitive to assumptions. So along the way, we were engaged by the US Society of Actuaries and the Canadian Institute of Actuaries to do something called enterprise risk management. This is a tool that was news to me, but that actuaries use quite a lot in private sector consulting for firms when they make a forecast, for example, of how much revenue they're going to get from sales. They'd like to understand what the risks are in that forecast. To our knowledge, this is the first time that this kind of tool, ERM, has been applied to a public sector program, in particular Canadian long-term care. So what we did is we start with a baseline projection scenario. We went out and sought a dozen key informants across the country with different roles in the long-term care sector. And we asked them all in a series of interviews, what are the major risks that they would see relative to the baseline projection that I just showed you. And for each risk scenario, once they described it to us, we went back to the model and we estimated what its impacts would be on key outcomes. And we focused on only two of those outcomes: how much would it cost the government, and how many informal care hours would be involved. There are obviously others, but these were the ones we focused. And then there was an iterative process. So after first eliciting the major risk scenarios and then going back and running the model more times, we went back, gave them the impacts and asked them as a group, not one at a time. You know, they could all see each other's scenarios, how likely they thought these scenarios would be. So what I'm showing in this rather busy slide is, you know, there were 32 risk scenarios we ended up analyzing. So this is a selection of the mostly the more likely ones as people, as our key informants informed us. And the first two columns show what is the impact on dollars qualitatively and on hours. So the top one says, well, some people said what's going to happen is, and this was the top one, more seniors are going to stay at home. But if they do that, and then they would use home care, is the average acuity of people needing home care would go up, and the people left in nursing homes, since the milder ones would have shifted to home care, their average acuity would go up. So it would entail many more hours of care, informal or formal, and not increase costs that much. Another was increasing public pressure on, again, where's my cursor gone? There it is. To increase quality of care. Now remember, this is back last fall, before COVID and before all the crisis. So this was already identified as a major possibility. Screening for dementia, there's quite a bit of talk about that. Also, again, where the heck is my, there was near unanimity that personal support workers were seriously underpaid. And so that we did a scenario where their pay would be increased by $10 an hour. We've also heard about the, my goodness, my cursor keeps disappearing, the inability to maintain the aging physical facilities. Well, we've certainly heard about many long-term nursing homes having 4 beds and things like that. So there would be substantial capital costs involved in replacing those. The bottom one, class action litigation over elderly abuse in nursing homes, another one that was highlighted last fall. So in addition to those kinds of things, I've already indicated that there are uncertainties with respect to our mortality projection, that recent leveling off and mortality improvement, disability projections. Patterns of long-term care utilization. I have to confess to my frustration. In 2004 and again in 2017, the federal government gave massive. In 2004, one of the priorities was home care, and there was supposed to be money spent in improving data. In 2017, the 2 priorities were home care and mental health and addiction, but no new data is emerging. There undoubtedly are going to be changes in the budgetary costs of long-term care. The unmet needs, we've made an estimate, but it's pretty rough. There's a question of who's going to provide informal long-term care. And the scenarios that we simulated last fall for the enterprise risk management exercise included stories or scenarios where fewer, greater numbers of people were getting home care who were otherwise in nursing homes. So there's a question of how that shift from nursing home institutional residence to home care would affect the progression of frailty. There's no data on that. We made some guesses. So far, I haven't connected this to pension policy, but as you saw in an earlier slide, there's an awful lot of utilization of retirement residences, which cost $60,000, $70,000, $80,000 a year to be in, plus people, even when they're at home, are paying for supplementary help. In other analyses, I've argued that our retirement income system is going to result in significant declines in people's level of living standards, so that the ability to afford the kinds of products could be adversely affected. And finally, we've gone through in Ottawa recently a major, I won't call it a debate, I'll call it a fight about changing the urban boundary for the city. The major point of contention was with regard to urban sprawl. If we have, and one hears from time to time the phrase, we would like to be able to age in place, but if those places are out in suburbs and they're far away from services, not only will people have greater difficulty as they age and lose their driver's licenses coping with getting their daily necessities or related, the home care workers, the PSWs, who have to travel around will have important diseconomies compared to a situation where seniors were living in more congregate or closely, physically more closely situated housing. Federal-provincial relations, I have to say a few words. I've already started about dollars and data. So I haven't made a distinction in the projections between what the federal government would pay and what the provincial government would pay. But it's clear from the media of late, if nothing else, that there are major public pressures for a stronger federal role in long-term care. And there were some rumblings in the media a couple of weeks ago that perhaps the infrastructure funds that the federal government has already earmarked or set aside or planned to spend could be used for new capital costs of new long-term care institutional facilities, nursing homes. And at the same time, there are calls for increased regulation. And a key area of regulation would be staffing. There's obviously a broad sense that the staffing in nursing homes is seriously inadequate. We're not hearing anything about staffing for home care, but same stories there. The federal government, to my view, has a very long history of timidity with regard to attaching any strings to this funding conditionality. The data on current staffing levels, not just at the national level, but I think in many provinces, is horrible. So let's imagine that 12 to 18 months from now, the federal government is sitting down to negotiate the details of a new fiscal transfer for long-term care. If nothing is done, they won't have a clue what's going on in the provinces and what would be sensible in terms of the kinds of regulations with respect to quality of care in nursing homes and home care ought to be. So I've already been arguing a little bit in the media that no tiki, no washi. The federal government really should say, we're not going to give you all of the money here for long-term care or for building new nursing homes unless you start providing decent data. And to put some teeth into it, to say, furthermore, as is in principle the case under the Canada Health Act for physicians, if you don't give us the data, we will withhold whatever, 10, 50, $100 million a year and give it to Statistics Canada and ask them to just go out and collect the data directly. By the way, I think this should also be happening with mortality data and with the data on testing for the COVID, but I haven't seen any sign that the federal government is doing that. In any case, let me move on a bit. Given the scandals that have emerged with respect to nursing homes, long-term care costs will increase. And given the scale of informal care and the extent of unmet needs, home care also needs increased funding. Let's consider two main sources of funding, general tax revenue or some sort of public social insurance program with a degree of pre-funding. This would involve some sort of a surtax or contribution, and the accumulated funds would be invested in a manner like the Canada Pension Plan. As you'll see, I'll give away the punchline. I think this second idea is not very good, but a number of people have been talking about it. Plus, you can have various hybrids, and no matter what gets done, there would be a continuing role. I don't see it in the cards that the federal government would ever pay enough to obviate the needs for a very large amount of informal care. From time to time, people say, well, let's let the private sector do it. From an economic theory or conceptualization point of view, aside from the empirical observation that it's failed repeatedly, there's the issue of adverse selection, that the private sector or individuals are unable to pool the risks, and poor actuarial predictions mean there's higher risk premiums and excessive costs. And if you hadn't seen it, just about 2 years ago, the GE Capital took a $6.2 billion write-down because they were unable, well, they bought a firm that had done a terrible job of doing the risk analysis and predicting the costs. So let's go back to an illustrative social insurance component for long-term care funding, given that the cost will increase significantly, but it only really starts to happen, as I showed earlier, after age about 80, which in terms of the baby boom cohort here and now would happen after 2030 or 2035. Let's be clear that there are two key aspects or meanings for social insurance. One is pooling risks, and in this case, it's longevity, illness, and disability. That's absolutely essential no matter what we do. But the other is financing. And if we think of the Canada Pension Plan or employment insurance, there's an earmarked tax, more so with CPP than EI, there's pre-funding. On the other hand, we have major programs, the old age security pension, doctors and hospitals, which are funded out of general revenue, and there's no pre-funding there. Another aspect of the Canada Pension Plan as a social insurance model is important to note, which is that the amending formula is more like the constitution of the country, as opposed to a program that the federal government, for example, or a province could unilaterally amend. And for those of you who have the longer memories, this was at the heart of in a way, of the homemaker pension debate in the early 1980s. The women's movement wanted homemakers to be recognized in the pension system in the Canada Pension Plan because they believed, I think incorrect, in the end, strategically a mistake for the Canada, because it had this tougher amending formula. They would have been much better off pushing for an increase in old age security. And the CPP fund generally has had excellent yields, but let's remember that the CPP, I think, is only about 20% funded. So here's a illustrative scenario. We increase the unit costs from $175 to $250 per bed day. One of my colleagues hates referring to bed days because nursing homes are for the people who live their homes, not institutions. Home care unit costs from $30 to $40 an hour. Remember that this includes overheads. Let's assume that home care coverage is expanded to cover 10% of previously provided care that was previously provided informally. And to try and deal with this okay boomer stuff, let's suppose that a fund is actually going to be accumulated based on 2% of taxable income, or about 10% of income tax payable. But just for the sake of argument, it would only apply to people age 45 and older. The fund would start collecting money this year, 2020. The payouts would start in 2030. That gets a nice but typical yield, 3.5% real. It would cover 50% of publicly funded long-term care starting in 2030, and the balance of these expenditures would be funded on a pay-as-you-go basis from general revenues. And here's a graph that shows the results of that rather simple, and I don't want to make any claims that it's a realistic, but it's intended only to be illustrative scenarios. So the big humped line on the top, I'm a little colorblind, so I can't tell you what color it is what the fund looks like. So it grows and grows for 10 years from 2020 to 2030. And then it starts getting run down. The total cost of long-term care would be along here. Line is what would be paid for from the personal income tax, all of it, and then the money from the fund would start getting drawn on. So there's a drop in 2031, and it goes like this. Not terribly exciting. So what do we think about that? So inevitably, there are intergenerational transfers here. So the illustrative option tried to spare the cohorts while they were less than age 45, but those who are age 45 to 80 would still, in a way, pay twice, because they would pay into the fund when they're, say, 45 or 50, and then decades later, well, they would pay into the fund, and they'd also be paying the general tax revenue. And there's no, the rate of return isn't that important, I think, in terms of the intertemporal transfer, more in a second. So there's no significant financial saving. So the important thing here is that it be publicly funded, so that there's risk pooling against severe and the risk of severe and long duration disability. This long-term care insurance will inevitably be partial funding. There is, Germany has had a payroll or contribution rate for its long-term care, but it's been there for decades. So the phase-in is not an issue. Here we're talking about a phase-in there's no way you're going to stop funding long-term care while we wait for this fund to build up. It might be considered unfair for those 45 to 65 or 45 to 75 because they're paying both to the fund and to the general tax revenue, but c'est la vie. Furthermore, intergenerational fairness is a much broader issue than just these focuses on one or two programs and taxes. There's a long debate about the issue, and the idea that more household saving yields higher economic growth is dubious, and intergenerational transfers also include more than these narrow financial things, particularly if we bequeath our kids a lousy environment. That's not good news. So let me draw to a close with a couple of concluding comments. First, on data and methods. We've made use of the LifePaths microsimulation model, but it's been terminated, and we've been able to use a mothballed version of the model. I'm a great fan of this kind of modeling, and it really is a shame that it's not continued. The good news, in a way, is that ESDC has finally let a contract to rebuild something that's a more limited version of LifePaths over the next 4 years. Not sure how well that's going to come out. This analysis, and it's characteristic of microsimulation models of this in these kinds of areas in general, is a huge gobbler consumer of data. But in many key areas, these data are seriously inadequate. We don't know much about disability, as much as I would like, about disability prevalence, changes over time. I've already mentioned we don't know about staffing. We have only weak data on unmet needs. There were these major federal provincial fiscal transfers in 04 and 17, but they had essentially no strings attached. I did talk to some colleagues in the law faculty over the last several months. Statistics is in the Constitution as an exclusive federal jurisdiction. There is peace, order, and good government. There's the spending power, leaving aside the power for quarantine. So the federal government has every right to collect these data, and maybe some of you who are listening in, I'll be interested to hear your comments. I still despair or don't understand why the federal government has been so timid in exercising these kinds of powers. I've only shown you one illustrative scenario. Many others can be explored by varying the parameters. Back to the data, the business of using federal infrastructure funds for building new nursing homes, why doesn't the federal government insist that no tiki, no washi, no data, no money? And finally, publicly funded long-term care is a form of social insurance for the risks of severe and long-duration disability and functional limitations. These risks cannot be funded individually or by private insurance, but private pay top-ups, I think, are okay and indeed will be inevitable. And this, it seems to me, differentiates long-term care from the areas covered by the Canada Health Act, hospitals and doctors. There, if a doctor wants to bill privately, he or she gets paid zero from the government, according to the Canada Health Act. Whereas in the case of home care and nursing homes and retirement residences, it seems that that kind of a restriction is not appropriate. So that it may be better part of wisdom that something separate from the Canada Health Act be used for articulating or specifying the federal role here. Long-term care cost pressures have increased dramatically in recent weeks due to the pandemic crisis in nursing homes. But I don't think, for example, the Premier of Ontario, Doug Ford, when he says, well, we're immediately going to raise the pay of PSWs, and we got to get rid of these 4 beds per room nursing homes, has thought about the longer term implications in terms of funding and costs. On the other hand, if we look not at constant dollar costs, but at costs as a percentage of the economy, we're talking about going from maybe under 2% to maybe 4% over the next 30 years. This is certainly affordable. It's been afforded already in other countries, and they seem to have very nice quality of life. The idea of pre-funding long-term care costs, even though some people, when they talk about social insurance, have this in mind, doesn't avoid intergenerational concerns. So I don't think, and doesn't seem to help. And long-term care, unfortunately, because I've spent quite a time trying to understand or think about and I guess push people, our key informants, can you think of any way that we can bend the cost curve for long-term care? You know, anybody who is knowledgeable on hospitals, doctors, and drugs will say, sure, you can do this and this and this. But in the case of long-term care, I'm afraid I've been unable to find very much that would have a significant impact. So I think Canada can afford its aging population, but in the case of long-term care, we are going to have to afford more. Thank you very much.
Thank you very much, Michael. Yeah, that was fabulous, drawing our attention to one of these wicked problems in terms of policy development, that will stay with us for the foreseeable future, huge demographic changes and also an enormous amount of funding that has gone into this sector, but we need to expand to keep it at a quality that we need and desire. So I would like to open the floor. You could, we have a raise the hand, but let me know please in the chat box if you want to come in, or and then unmute your mic and your camera if you'd like. Who would like to start us off with a question for Michael? Let me slightly different this system here in terms of the raising hand, but I think you can, with a reaction here, you could let me know if you would like to come in. It's hard to read the room in this virtual world, so to know who would like to come in first. No need to be timid in Zoom.
Oliver and Michael, Ted Sheldon here.
Yeah. Ted, please go ahead.
Thanks, Oliver. And marvelous, Michael. Thanks. My goodness, lots of information, lots of data. Not too sure how to ask this question. Maybe in simplicity, you mentioned the 1.8% GDP in Canada and was it 1.8 and then something along the lines of 2.8 in the Scandinavian countries. I'm wondering the balance or the mix of private versus public between the two groups, primarily public in Canada and presumably largely public in the Scandinavian countries as well. Would that be a factor in terms of the percentage of GDP influence?
I should double check, but I'm pretty sure the numbers were all public sector costs.
All public sector costs, okay. So then I'm wondering, maybe just an add-on, to what extent that might speak on the one hand to the higher level of quality in the 2.8% countries, if you will, versus what might on the surface look like in Canada at 1.8-ish or so, look to be more an efficient, a measure of efficiency.
I don't think the lower cost in Canada is efficiency, it's underfunding, which we're seeing in spades in nursing homes. We're not seeing it in home care because that hasn't been in the news related to COVID, but the unmet needs data that we see in the various population surveys, while not huge, 10 to 20% of people over 75 are saying we have unmet needs.
Great. Great, thanks for that.
Thank you. Michael, could I read a question from Stuart here? Thanks, Michael. Very thoughtful presentation. Regarding funding, what is your view on using an increase in GST, HST as a funding source for long-term care? Regressive tax, yes, but probably a cause that would be widely supported. Any thoughts on this source of revenue through taxation?
That's a classic question of tax mix, and I remember in the Department of Finance, people struggle over that. There's the distributional impact, but there's the old line that the art of taxation is figuring out the least painful way to pluck the chicken. So raising GST, some mix of those kinds of increases, I think is, income tax, corporations, and GST, HST, sure. The regressivity of an increase in the GST, HST can be almost fully offset by increasing the refundable sales tax credit, or whatever the name of it is these days. So I wouldn't worry about that. Economists like to worry about things like behavioral responses, and so there's fear that raising the income tax would have a greater adverse effect on labor supply than raising the GST, HST. However, that gets us into a whole other area, the long discussion, at least in some areas, about the basic income and related to poverty traps. The high income people squawk like heck when they see marginal effective tax rates going over 50%, but people at the bottom end of the income spectrum already face effective marginal tax rates well over 50%, in some cases over 100%. So, and corporate taxes, it's been years since I looked at it closely, but my sense is it's still the case that nobody knows who bears the corporate tax ultimately because of tax shifting, whether it's back to consumers, forward to consumers and prices, back to workers, or as many on the left would like to believe, on shareholders. And again, ignoring the fact that they're often shareholders through their private pension plans. So yeah, perhaps a longer answer, but I think the part of the revenue source could certainly be GST, HST.
Staying with the issue of affordability and funding, Chris has this question: can we afford pharmacare and long-term care? What would your priority be? Can we walk and chew gum at the same time? I'm not sure whether you want to stay in this picture, but clearly there's some choice to be made in terms of where we invest the funding.
Well, I think that's an easy question, because the net effect of pharmacare would be savings, $4 billion at least. The trouble with introducing pharmacare, I published a Canadian Tax Journal article on this with Steve Morgan half a year ago, is that the federal government would have to raise taxes. At the same time, particularly employers, those who offer drug plans, would save a lot of money. Indeed, the federal government would save money because the cost of their drug plan for public service employees, and I guess for B.C. employees as well, would go down. But there's an unscrambling the omelet kind of question there, because the savings from the federal government stepping in and raising the required taxes to pay for a proper pharmacare program, it would result in all benefits, but it would be very difficult to recoup those in any highly targeted way. But what we did in the paper a year ago was say, well, you could do some mix of corporate tax increase and other things. So I don't think it's an either or at all. I think that the pharmacare, in fact, in principle, could save enough money that it could be reallocated. Similarly, getting a handle on inappropriate care in hospitals, 16% of the beds in Ontario, hospital beds, are what are called alternative level of care, which means they're basically people who should be in a nursing home or at home with home care, but they've been unable to be placed. So if we save that money, that could also be used to do a better job of funding long-term care. With respect to doctors, there's some people who said for a while, we have unemployed cardiologists in walking around in Toronto. As coronary heart disease declines with decreases in smoking rates, maybe going up in relation to obesity, but whatever, we don't need that. And the analysis that my colleagues and I did a decade ago, showing this terrible relationship between 3 times as many heart bypasses in one part of the country than another, with no obvious benefit in terms of survival. There's lots of wasted money as far as I'm concerned.
And Michael, maybe that gives me an opportunity to raise a question myself here, because you spoke so passionately about the proper use of data, of proper information about these things. And you seem to suggest, and sometimes you were quite explicit about this, the unwillingness from some of the provinces or some of the stakeholders to provide and gather the data that is needed for good policy making. I'm just wondering, is this just sloppiness and not thinking through these issues, or is there a political strategy that without the proper data, certain decisions don't need to be taken? I'm just wondering, you said even tie funding to the proper availability of this kind of data. I'm just wondering, where's the problem of gathering this? Is this just we can't agree on how to do this properly, or is this even a political calculation of not making those data available?
Let me divide the answer into two parts. One is the federal role in data, and the other is why is there resistance to a lot of these kinds of data. The first one, I despair. I don't really know. I did have some inside knowledge back in 2004 when the First Minister's Health Accord was done, and the word accountability was in that accord quite frequently, and there was a clear intention to work with the provinces and collect data. Nothing happened. The federal government has put billions of dollars into Health Infoway Inc. Health Infoway, one of its core objectives back in 2006, 2007, was to create an outbreak detection system. Had they succeeded, we would have had that long ago. We don't have it. But the Infoway, the tools at their disposal were only 50 cents, sometimes 75 cents on the dollar, and they had to cajole the provinces. So why the federal government keeps chickening out of compelling the provinces, I don't know. More generally, there are, I've referred to several things, the privacy chill. There's, if you are a data custodian, for example, the vital statistics data on deaths, or the, more recently, I guess, the data on testing, if any of those data get out, you're going to be in trouble if there's a breach. But if somebody's able to do some arcane stuff with a projection model to say, here's what the epidemic curve is going to, data custodian has no upside benefit. So there's this asymmetry with respect to privacy. I wrote a column about this about a month ago, and I was quite pleased to see that the Federal Privacy Commissioner, within a couple of days, published a statement that said, it seemed to say we're not standing in the way of use of these kinds of data. But there's no voice that's out there saying there's been overkill in terms of concern about privacy. But I think there are also some more other important things. There was, one of the outcomes of the First Minister's Health Accord, at least in the first year, was producing a bunch of data. And the Conference Board came along and did a league table of how the 10 provinces were doing. And as I remember, Manitoba came out at the bottom. And the Minister of Health in Manitoba spent 2 weeks being grilled by the media and by the opposition in the Manitoba legislature. And my colleague in the Manitoba Ministry of Health said, Michael, we don't ever want to go through this again. So that the risk to the politicians is very high. And, of transparency. Somehow we've gotten over that hump decades ago because the Minister of Finance doesn't seem to have any scars on his back from publishing the unemployment rate or the inflation rate, right? So we accept the fact that those kinds of numbers really are important public good numbers, and we also understand that the inflation rate or the rate of economic growth is multifactorial. There are many things that drive it, and so you cannot blame the Minister of Finance for everything, although the opposition typically tries to do that. But that's a factor that we haven't arrived at that in the area of health. And finally, I have to mention the medical community. Many doctors, particularly younger doctors, are computer savvy, but I think there's a critical mass of physicians in the leadership of the medical establishment who know full well that if I could publish the kinds of data I did on heart attacks and others on a regular basis, they would be embarrassed, they would become under what well-deserved pressure, I think, for as gatekeepers of the healthcare system to say, you guys need to clean up your act. And it's in their interest as a union not to want to have people looking over their shoulders at how they're performing.
Yeah, it's fascinating. If you consider the COVID crisis now, data are not themselves political, but they have a political weight and effect, right? And so you could probably do interesting case studies about, the availability of data and what effect this has in the policy community and political debates and so forth. Anyone else who would like to come in? I'm not entirely sure. I see, if there is a willingness to raise a question here amongst you. So please feel free also to simply unmute your mic and come into the discussion if you feel so inclined. Anyone who would like to be next? In our boardroom, that will be a good moment to get a coffee, but since we can't do this, anyone would like to join us? If not, Michael, maybe one more question. Maybe people think about their question at the moment. It's striking for me to hear, or is there someone else?
Oliver, I was wondering if I could have a...
Oh, Rod, by all means, please.
Yeah, Michael, thank you very much. As usual, it's impressive, authoritative, and persuasive. I wonder whether, this question of federal provincial arrangements presumably is going to be a substantial topic as we come out of the pandemic and try to make sense of the situation with all transfers in place and all of the complicated arrangements that have been on sharing some of those emergency transfers. There's going to be negotiations. It would be wonderful, as you say, if some conditionality really could be used effectively. I'm wondering whether in those transfers we're going to see a need to deal with Indigenous governments, First Nations governments on a variety of questions around federal, provincial, First Nations fiscal arrangements, and wondering whether the circumstances for long-term care in First Nations communities are topics that have been explored or would need to be addressed. And I guess there's also that question whether there are particular problems with urban Indigenous residents who I guess are about half of the Indigenous population. There are a number of long-term care facilities that are created by particular groups for particular population subgroups. I don't know whether any of these questions around the particular circumstances of long-term care for the Indigenous community are being explored.
Great questions, Rod, but short answer is I don't know. And in terms of data, the data for the general population is difficult enough, and I'm not perhaps the PALs, the post-census surveys, have enough sample size to be able to include the off-reserve Aboriginal population, but I confess I haven't looked at that in particular. And I think there's a whole broader set of complexities when one starts talking about funding and relationships with the on-reserve community. So I'm sorry, I have to plead ignorance on those aspects.
Well, any follow-up?
Well, just to wish you luck on the whole drive to get the conditionality into these arrangements, and maybe somehow find a way to restore life paths to life.
Thank you. I thought I saw in the chat something, Oliver.
Yeah, let me see. I think that's the last from Chris. I might have, or am I missing here anything?
No, the one from Stuart, is that about GSTP, HST?
Yeah, I think that's what we covered. Let me see. Oh,
Oliver, it's Chris Lawless calling.
yeah. Go ahead, please.
I did try to type a question in there, but my dentist's office phoned me right in the middle of the whole thing, so I
Right on.
kind of messed it up. Sorry. Michael, I got a question about Lawrence Kotlikoff, who I don't know where he is now. He's at Boston University or Boston College or someplace. Wrote this stuff on generational accounting years ago, and I imagine it looks terrible now for the U.S. But what's your sense of when we look ahead at these challenges? You mentioned the pension one. You mentioned, I had the question about pharmacare and long-term care. But you sort of indicate that yes, with rising national wage bill, we can actually afford this stuff. What's your kind of take on this generational? Again, in the U.S., it looked pretty dire in terms of the affordability equation. What's your sense on that for Canada?
Well, it's been a while since I've looked at the literature, but back in about 15 years ago, Kotlikoff and Orbach and others were very keen on this generational accounting. It was very fashionable here in Canada. Aureopolis, and I can't remember the other fellow's name, did a paper on it. Jeff Rowe and I cranked up Life Paths, and we basically came to the same conclusion as the Economist magazine that I quoted at the beginning. What we did is we used essentially the same model that I've used for these projections, and we looked at taxes paid over the life course relative to education, healthcare, and pension benefits received. And first we looked at how much intergenerational flows there were, and there were some. Then we looked at the flows between men and women. Those were really big. And then we looked at the flows between income deciles, and they were even bigger. And then we looked at how much of the variability at the micro level we were actually explaining by the combination of generation, sex, and income decile, and it was like 25%. There's so much heterogeneity, at least in the way that we were able to simulate it 15 years ago, that my view, and I see no reason to change it, is that the biggest question is not intergenerational. So this okay boomer stuff is trying to make an issue out of things that are, it's second order compared to the differences by income group and between men and women. And I think there are other characteristics of individuals that we hadn't looked at a long time ago. Furthermore, the Kotlikoff, et cetera, kind of analysis, if you dig into it, makes these ridiculous typical mathematical economic assumptions about, there's the previous generation and then there's generation from today forward, and we're going to use, infinite time horizons, discount rates. It may look like it's empirical, but it's just laden with assumptions that are patently false. I don't know if that's enough of a diatribe or whatever.
Unless there is a follow-up, I would like to go to the chat box again. Claudia Lewis asked a question. Canada is having a federal structure. It does not make much sense to me to compare the situation here with Scandinavian countries. Do you have any information how matters are dealt with in Germany, which is also a federation? So having the multi-level governance approach here, the jurisdiction on health is primarily with the provinces. So is there also maybe an advantage of having a centralized system where the federal government is squarely in charge?
Well, I don't think even Sweden and Norway have centralized systems, because what they do, and I confess I don't remember the details, but they have dozens of regional authorities that run long-term care. I can't remember whether it's Sweden or Norway. Germany has the Länder, so that there's already a division of authority. And I'm not sure that 100% of the funding in those countries is from national sources. So, yeah, one likes to make a comparison with, say, Australia and Germany as federations, but the structures it would take more research, or more in my mind than I have, to really answer that properly. But the other thing is, I don't think the key question here, or we don't necessarily have to look at federations rather than unitary states or general unitary states in order to take a lesson and say, as a country, we can afford this. And then the question is, how do we make sure it actually happens? And of course, I am nowhere suggesting, by the way, that the federal government should take over the provision of long-term care. I'm perfectly happy, and the Constitution says that that's primarily a provincial area of jurisdiction. The key thing is that if the provinces are coming to us and saying, we want money, and the public is saying the federal government should give the provinces money in order to do things better, then as a federal taxpayer, I wear several hats. One is a federal taxpayer, another is a provincial taxpayer. But as a federal taxpayer, I would like the federal government to be accountable for how they spend those federal provincial fiscal transfers. And part of that should be, give us the data so we can tell how you're doing. Are you really doing what you say you're going to do? And often they don't. And then, make sure that they do it, with penalties.
Michael, as you might not be surprised, another question on the financial, challenges that long-term care faces. That's coming from Pam, thanking you for an excellent presentation. I wondered if you could expand on the no financial savings in long-term care programs, for example, with the increased stay at home. Why isn't there any, any savings here? I guess, what is the question? And, you spoke about that. I'm not sure whether you recall from your presentation about the limited also possibility to create savings.
Yeah, well, I wish I knew. My intuition is that we could probably save some money if we were able to have more people stay at home and be cared for rather than going into an institution. But in our previous, a lot of this research was funded by a CIHR grant. And as part of that grant, we had co-investigators from the Netherlands and Germany. And in both countries, they actually have systems of payments, kind of a voucher system, so that if you are going to provide informal care, you can get some money to compensate you for that. But the key thing is that when the amount of informal care exceeds a certain number of hours per week or per day, it's more cost effective from the broader perspective for those people to be in an institution. Instead of having a personal support worker run around and spend 2 hours here and an hour there, it would be a lot easier if those people for whom the PSW was providing care lived 5 minutes apart rather than a half hour or an hour drive apart. But there will come a point when the amount of care is such that it's more cost effective for people to be in a institutional or fixed facility setting. Leaving that aside, I've tried pressing lots of people over the last year or more that we've been in this to say, are there no data at all that we can look at to say that for this level of functional limitation or these kinds, shouldn't there be fewer people in nursing homes where it costs more, $175 a day, and more at home? And I've been unable to, all I can say, it may exist, but I've been unable to find that kind of information. And judging by the amount of unmet needs that people say in StatCan surveys, various disability surveys that they face, if anything, even with the current caseloads in nursing homes vis-a-vis in homes, private homes, more money could well be spent on home care.
Michael, just a quick additional question on this one. Did you raise any data and collect any data on the gendered effects of, increased home care? How would it, because that's what we see at the moment with the COVID crisis, that much of the brunt in terms of educating children at home, having home office and educating children is often on the shoulders of women. Do you have reliable data of how a shift towards more home care affects women in particular, their professional careers and so forth? that could be one unintended consequence, right, of shifting the responsibility more towards private homes.
Yeah, there's two parts to that question, if I may. One is, what is the role of women vis-a-vis men? And there's no question that women are the primary providers of home care. The second part, though, which we've been asked, but I confess I don't know any way to get the numbers, is what is the effect on women's labor force participation, adult children with frail elderly parents, of having to provide more care? There's all kinds of anecdotal evidence that many women have to drop out of the labor force or reduce their hours of work much more than men. But in terms of being able to do some kind of econometric analysis, there may well be papers on that, but I'm not familiar with them off the top.
I'm wondering, we're coming very close to the end of our session. Is there any last question that one of you around the virtual table here would like to raise? If not, we could use the last 5 minutes or so to gradually move over into a more informal chat. We can't replace what we have at the center, where we just, mingle a bit in the hallways and over coffee. But unless there is one last question for Michael, if not, I would like to thank you very much, Michael. I think, as you could see from the comments and from, also the people who called in, an excellent talk. And I wish policymaking was based on such solid empirical basis as you did demonstrate here and now. I think we see some challenges out there, where we don't have the proper data, or the data is not being used. And I think you gave us an excellent example of how we can think through even very complicated policy issues through solid empirical data that we collect and evaluate with respect to those challenges. So thank you very much for doing this for us today. And it seems you picked a very topical issue that will stay with us for sure. The COVID crisis now, we've seen dramatically, capturing the attention of the public, but clearly with the demographic change, these issues, these are fundamental policy changes society like Canada will have to do. So thank you for shedding some light on this today.